We're going to have Dr. Jen Rakesh. Jen, come back up. I've already introduced him. He's going to talk about beyond depressive symptoms, addressing cognitive effects, sexual dysfunction, and weight gain in major depressive disorder, all of which, as we all know, are extremely challenging when people are on chronic long-term antidepressants, often lead to non-adherence and discontinuation. Rakesh, all yours.
Well, good afternoon. Oh my God, what is your blood sugar? Where's your energy? Is it there? Yeah, it's too cold. You gotta almost clap to do that. Well, listen, we just had a wonderful morning, I think. What do you think? Yeah, pretty good? All right, good. All right, that brought some applause. And do you remember the title of this conference? Elevate. Do you feel elevated in your knowledge base? Okay. Do you feel elevated in your empowerment? You feel empowered? You can take on some of these extra challenges that perhaps yesterday you didn't quite have the tools? Then I want to continue the conversation by not talking about major depression, but certain aspects of major depression that are truly underserved. And those are the three topics that you see on the screen here. Shall we rock and roll? Let's do it. You already know my disclosures. In terms of disclosure here, we make sure that all of our presentations at Psych Congress are reviewed 2 or 3 times by completely blinded individuals. So what comes out is something that I can take home and have belief in its validity and reliability. Learning objectives, this is a pretty demanding presentation, this particular one, because I'm not going to hold back. I'm going to show you the controversies, I'm going to show you raw data, and we will together have to make decisions. How do we actually tackle these 3 very common problems? All right, everybody, there are people here who have been in residency training for 9 months, and there are people here with 40 years experience. For all of us, this is true. No matter where you go, there you are. Have you heard that expression? No matter where you see patients or fellow human beings who suffer from depression, they will have all 3. You find me a patient who doesn't have all 3, suffers from major depression, that'll be a first in my career. And I've been a psychiatrist 29 years. So I think by now we know the emotional symptoms very well. Physical symptoms we're beginning to recognize. Pain came to our consciousness. Pain came to our consciousness just 10 or 15 years ago. It's time for cognition to come to our consciousness. Usually when we think about cognition, all we think about is memory. But in major depression, it's above and beyond memory. It is things such as decision-making, planning, organization, speed of thinking. All of those are cognitive deficits associated with major depression. Think of it as a triple hit disorder that majority of patients suffer from. This is very distressing. This is extraordinarily distressing. We must spend some time talking about it. 19 out of 20 human beings who suffer from depression will have cognitive dysfunction. That's bad. What's really bad and what's extraordinarily worrisome about cognitive symptoms is even patients who respond to treatment. And by the way, our definition of response until very recently was improvement in emotional symptoms. 7 out of 10 still have cognitive problems. I'm not done with distressing you, sorry. Almost half the patients who are in remission from emotional symptoms are suffering impairing cognitive symptoms. So, remind me, if you will, please, how many DSM-5 symptoms are there for major depression? 9, you got it. 4 of them are emotional. 4 of them are physical. Only 1 out of 9 is cognitive. So technically speaking, you can lose depression and still sadly have quite a bit of cognitive problems. Does anybody here have a friend or a family or unfortunately yourself ever suffered from major depression? You know the cognitive power of this disorder. It's astounding. more bad news. There's quite a bit of bad news, sadly, I have to share. When depression comes and goes, cognitive challenges don't always improve. In fact, one of the few aspects of major depression is the continuous deterioration of cognition. We often say depression is a disorder of the way you think. Sometimes there's truth to how we describe it. It's actually quite a bit of challenge. All of a sudden, I lost the feed here. Colleagues in the back, folks, in the back. I have lost the feed to the confidence monitor. If you could perhaps reconnect it. All right, anybody been on call? Of course, everybody has been on call before. This is what has happened to your memory and cognition right over there. This is what has happened. Now watch this. Having chronic depression looks very much like not having slept for an entire 24-hour period. This might get your attention, no pun intended, as to how far and how badly cognition is deteriorated in major depression. We don't let residents work for us beyond a certain length of time, not because we care so much about them. I wish we did. We do, residents, sorry, we do. But because we care about whether they're going to make mistakes. We don't let nurses work longer than a certain number of hours. Again, not because we particularly care about them. I'm joking. But we care about the cognitive deterioration that would happen. So look at that. Look at that. Look at the cognitive deterioration of major depression. It's profound. But I'm really surprised why I didn't think about cognition when I was in training. And it probably was because I was trained to think of major depression as an emotional disorder. So here's a key point to remember, and I think it's really key, unless you disagree with me flat out. Cognitive dysfunction is common and is impairing. Let that sit with you for a second, because then perhaps you can think, so when I have assessed patients, have I really looked for cognitive difficulties? And if you're like me, you're probably going to say, not as often as I should have. What about weight gain? You don't want to let this get away from you. Look at the first part, the left part of the slide here. What I'm going to show you is as the PHQ-9 score increases, meaning there's more and more depression, this is cross-sectional. I will show you longitudinal in a minute. So do the odds ratio of someone being depressed. Did you grow up with these following two expressions? Lean but mean. He's lean and mean. The other one is happy Buddha, as if being big and round makes you happy. Both are false statements. It's actually the opposite. Look at the right-hand side. As the BMI increases, so does the risk of depression. So no matter, well, let's look at it this way. No matter which direction you go, depression does lead to more weight gain. We shall look at why, but the reverse is equally true. More weight gain you have, the higher the risk you are, not only for depression, but for the antidepressants not working well. I'm first going to show you bad data, then I will show you good data, because I want to show you why is it that psychiatry lost its way? Why did we start thinking some medications were better than they really are? I really was trained to believe and to think of fluoxetine, Prozac, when it came out in the first 5-10 years, as a drug with no weight gain, until I could no longer deny it. Many of my patients were gaining weight. But how did we go so wrong? This is how we went wrong. Look at the slide behind me, if you will, please. Short-term data actually in some medication shows weight loss or weight neutrality. And when they said long-term, back then our definition of long-term was 3 months. Just 25 years ago, a long-term study was 3 months. And if you're really courageous, you did it for 6 months. So it is the truth. They were not lying. The problem was patients don't stay on medications for 6 weeks to 6 months. So what is the truth? This is one of the most important slides I'll get to show you all day today, maybe all the entire conference. This is not 6 months. This is 10 years. I need to actually walk you through this if I may. This is the rate ratio. This is the prescriptions. How many percentage of prescriptions are written? I hope you're noticing something interesting. After 10 years, we actually have no safe medications. Even medications like bupropion, which we have often said has no weight gain, actually have, in some people, about 7% of people who get bupropion actually gain weight. It's also true 9% lose weight. But if you're the 7%, that's not good. So if you're a statistician, there's no weight gain. 7% gaining weight, 9% losing weight. In the wash, no changes. But in real life, it happens. The key you must remember is this box. If you have a patient on an antidepressant, and sadly at the moment it doesn't matter which one. At the moment, we don't have a single antidepressant you can wash your hands off. The risk ratio is 1.29 if they started normal, meaning there's a 29% elevated risk of becoming overweight. If you start overweight already, there's a 29% added risk that you will become obese. So cockiness should be shedded. No longer should we tell people there are medications without weight gain risk. They have different weight gain risks, that's true. But weight neutral medications don't yet exist where I can guarantee you will not gain weight. 29% is a big risk, but you need a 10-year study to fully appreciate it. So here's the key point to remember. Antidepressants often, I may actually have to change often to something more powerful. Usually would be a better phrase. Usually cause weight gain, but it is also true. Different antidepressants, bless you, have different trajectories. Everybody with me? Anybody want to fight me on that? You won't if you have spent 10 years in practice. You probably will if you spend 1 year in practice. It takes time to see this problem unfold. Sexual dysfunction. Again, depending on the study, we have different rates. That is true. That is true. But even, I'll pick on bupropion again, there are plenty of patients who develop sexual dysfunction on bupropion. The numbers are much smaller. That is true. But if you're looking for a completely sexual dysfunction sparing antidepressant, I'm afraid you'll have to continue waiting. We don't have it. But how much is that risk? We also need to know that. And I've got actual numbers here for you so that you can examine for yourself. And men and women appear to be equally prone to this challenge. But this is not enough information. I want to know much, much more. But as Chuck said when he introduced me, he's right. All of these 3 side effects I mentioned are very common reasons for discontinuation. But you know what's interesting? Patients don't remember to tell us about thinking. They forget to tell us about thinking. Because they too don't know that cognitive dysfunction can be part of their medication. They sure do know sexual dysfunction is. They sure know weight gain is. But really, all 3 are major, major challenges. So the key point to remember one more time is antidepressants often induce sexual dysfunction, and that often could range as high as 70%. It can be very, very, very significant, and it's often a cause of low adherence, partial adherence, firing us, etc. So how do I assess it? Because Elevate is a meeting of learners and doers. We're all thinkers, but we don't stop at thinking, do we? We want to do something about it. I have brought for you specific tools. I really hope, I really do hope, at least a couple of them you will download and utilize occasionally. And the reason why I'm suggesting occasional is so that you get your feet wet and try to use these skills in people you don't think have a problem. Because if I already think you've got cognitive problems or sexual dysfunction, there's not much you will learn from it. But try this out in 10 people that you're sure don't have sexual dysfunction. Then give them the scale. And then wait in at least half of them to be shocked and surprised. Sometimes that's the best way to learn it. This is a very cool questionnaire to detect cognitive dysfunction. This is called the Perceived Deficits Questionnaire. As I have said to you before, if you ever want copies of any of these scales, etc., just find me during the next 3 days and I'll send you a package of them. The one I prefer is this one. We are in Boston, so it is good for me to highlight this scale, but this is the scale we use. This is the Mass General CPFQ. The reason why I like it is it catches two different things. It catches cognitive dysfunction and physical dysfunction, which, by the way, I often induce in my patients. I often make them fatigued or tired. We've done a number of studies using this scale, and we very much like this scale. It's quite sensitive to change. 4 of the items, look, if you can squint a little bit, 4 of the items capture the 4 elements of cognitive dysfunction and depression, those being attention, concentration, processing speed, and executive function. By the way, so does the questionnaire I just showed you, Perceived Deficits Questionnaire. Do this whenever you can, maybe in the next few minutes or the next couple of days. Pick one. But the one that you do pick, please try it out with patients you don't think have cognitive problems. And best sit down because you'll be shocked. Majority of patients will say, there is a problem. This is the DSST, Digit Symbol Substitution Test. Do not download it unless you love pain and suffering. But the reason why I'm showing it to you is because this is, however, a gold standard instrument used in FDA-level studies to find out if a medication intervention is helpful. So many of the data I'm going to show you is going to be based on DSST. Would you look at what it captures? Executive function problems, processing speed, attention, and working memory. Also kind of a short-term memory. It's a very good instrument to capture all 4. There's a computerized instrument that I don't have much experience with, but because many of you are younger clinicians and you very much like using online, iPad-based technologies, I wanted to let you know there is an instrument specifically designed to look for cognitive dysfunction in patients suffering from major depression. What about sex? Well, there are 2 instruments. Again, do not use both. Pick one or the other. This one has become FDA's favorite instrument. It's become so much a favorite of theirs for all the right reasons. Unless you have the scale in it, they will not actually look at your study. This is the CSFQ, Change in Sexual Functioning Questionnaire. There's a male version and a female version. 8 items are shared by both sexes, 6 items are not. So you really have to be specific, obviously, when you give it to the patient, male or a female patient. The second instrument, older, I prefer to use this one, but that's just because of familiarity. Use either one of them, is the ASEX. Now, why Arizona gets to talk about sex and not Texas bothers me, but so be it. You want a scale, have it, Arizona. But actually a pretty good scale. And here, males and females share items 1, 2, 4, 5. It's only item 3 that is sex dependent. Also very sensitive to change. Pick one, use it. Use it in people you don't think have sexual dysfunction, and be very ready to be surprised the majority of the time. It is that common a problem. So what are the key points I need to remember? Proactively explore the challenges patients are having. Weight, I don't need to explore subjectively, obviously. I can measure weight, but with cognition and sexual dysfunction, it is ideal to use scales. And here's why, guys. Tell me this. If you were to ask me, I'm your patient, we've talked about my suicidal ideations and my marriage problems and my financial problems. How do you explore my cognitive dysfunction? Let me hear from you. I'm your patient. What will you ask me? And typically the question we ask is, hey, how's your thinking going? How's your memory? It's not too bad. Okay, fine. How's your sex life? I mean, that's the question most of us ask. Come on, let's be honest. How about things in the bedroom? Or something along those lines. Look at this. It explores none of these items. Not only does it not explore it, there are 2 other problems. It's not rated. Here, it actually helps you rate it. One other advantage, I'm actually able to track it over time. When you came in, were you at a 3? Now you're still at a 3. Okay, at least I didn't harm you. Do you see what I'm saying? Oh, you came at a 1, and now you're at a 5. Uh-oh. Or you came at a 5, now you're a 1. See how much I lose out by not using a scale. So scales are not designed to make me lazy. It's not that I don't want to do my job. It's just that I want to be empowered, elevate. I want to elevate my ability to help my patients with major depression. I really want to encourage you guys. 1 scale for sexual dysfunction. Get really familiar with it. 1 of the 2 scales for cognitive dysfunction. And use it not because you're lazy, but because your heart is in the right place. Let's dig a little bit deeper. Neurobiology of this whole challenging issue must be kept in mind. This is very old, but don't you forget it. The relationship between norepinephrine, dopamine, and serotonin is intimate. Why do I care? And here's why. I don't know how good your eyes are. I don't know if you have high powers for squinting, but here's why. Many of these systems are designed to either stimulate each other or to depress each other. I'll give you an example. Has anybody ever treated a panic disorder patient without depression successfully with an SSRI? Sure. Has it worked? Sure. Why? Makes no sense. Panic disorder primarily is a problem of the locus coeruleus, a norepinephrine problem. Giving me serotonin is going to help my noradrenergic system come under control? Exactly. I'll just repeat what she said. She said it does, indirectly, by putting a brake on the system. This is why very often when we give patients our classic medications that do help with the emotional symptoms, we notice a flattening of their drives, their motivation, their cognition. It's not an inadvertent side effect. It's an advertent side effect. I caused it. I know what I'm doing. It's just that I wish I had done it. I guess what I'm trying to tell you is get to know the intimate relationship between these 3 neurotransmitter systems. Sometimes it's for good. I have a patient with a very, very high sex drive, has a gambling problem on top of it. I want to dampen his dopaminergic drive. His pleasure centers are just overactive. The drug of choice would be, guess what? An SSRI. I converted a side effect into a benefit. So it's not a bad thing or a good thing. It's just a thing. And in the right clinical situation, this relationship ends up helping my patients or harming my patients. Therefore, it's incumbent upon me to know my weaponry well. I need to know the difference between a scalpel and a forceps if I'm doing surgery. It's incumbent upon me. I can't just tell whoever's helping me, give me any instrument. I don't care, just put it in my hand. But why do we often do that with antidepressants? Let's start an antidepressant. No, which one? They all are different. So let's know our tools. Mike Pace, the first talk this morning, talked about SSRIs as medications that left a lot on the table. They left a lot of bad stuff on the table, which is great. They left histamine blockade and cholinergic blockade. Thank you for leaving that on the table. Residents here will never see what a TCA-induced death in an ICU looks like. Sadly, I got to see him because I came of age just as the TCAs were about to leave and SSRIs were coming in. They will never see one. I hope you never do. It's awful. There was nothing they could do. But why? Because those unnecessary receptors we didn't need. So we shed them. Problem is shed too much. So they're still very valuable, but we got to remember SSRIs, good, SNRIs, better. Better because we got one other leg pulled in. We got norepinephrine. But if you notice the last several antidepressants that have been launched in America are no longer monogamous, they're polygamous. And you might say polygamy is bad. Not if you do it right. I speak not from personal experience. My wife is sitting in the back and she's a Texan, so not from personal experience. I could be physically hurt. But because of this reason, I hope you're beginning to notice, even with serotonin medications, look what we're doing. Look where we're going. We're now going back to the 50s. Man, it took us 60 years so that we could go back 60 years. And this particular receptor, 5-HT1A, has become very important to psychiatry. It's become so important, everybody is looking for a drug that has some 5-HT1A activity, be it antidepressants or be it atypicals. Can you name the last 3 atypicals launched in America? Vraylar, Rexulti, Latuda. One of the features that all 3 share in common is actually very high 5-HT1A activity. Look at the last 2 antidepressants launched in America. Both of them actually happen to have 5-HT1A. That, of course, is vilazodone. This is vortioxetine. Vortioxetine, of course, went a couple of steps further and recruited several other receptors. There are 14 receptors in the serotonin family. The human serotonin family has a grand total of 14 receptors. This one goes after 1, 2, 3, 4, 5. They're all different. Which one's the best? Silly question. There's no such thing. What's better, a scalpel or a forceps? What do you need? Then we'll decide what is best and what is not best. But they're different, and therefore they'll come with strengths or weaknesses. Why are we going polygamous? And here is why. And I really want to ask our residents and our young colleagues and nurse practitioners in training, and we have both of them, to appreciate this. As of about 5 years ago, receptor pharmacology has come into its own. We abandoned it before because it didn't matter too much, but now we know how much it matters. I'm just giving you an idea. If you attack or modulate, even say the serotonin system appropriately, you end up with downstream effects that can be very helpful. For example, we talked about 5-HT1A a second ago, didn't we? So 5-HT1A is not just a autoreceptor. So if all I control is members of my family, then I'm an autoreceptor. I'm in my own family. But if I, as a serotonin 5-HT1A receptor, go live on a different family's neuron, say, for example, glutamate or GABA, I'm no longer called an autoreceptor. What am I now called? A heteroreceptor. Why is this important? This sounds like such geeky BS. This is why. Because a heteroreceptor, if you play it wisely, if you play your cards wisely, all of a sudden you get to recruit other neurotransmitters that can be of great help to you. Now hopefully you're appreciating why receptor pharmacology is a rich vein to tap as a clinician. And therefore, at least in this case, through 5-HT1A agonism or partial agonism, we end up modulating glutamate indirectly. And glutamate can have cognitive benefits. Aha, so all this BS that I just talked about is not for vanity reasons. It's because clinically I can do something about it. So yeah, get to know your autoreceptors and heteroreceptors. It can be very helpful. Let's change gears a bit. How is overeating a problem? I mean, that should harm my body. Why does it harm my brain? Sure, I've been called a fathead before, but what does that have to do with anything? So let's look at 2 things. The first thing what I want to point out to you is this is, of course, the functional neuroanatomy of mood. This is not structural so much as it's functional. When your default mode network lights up or goes offline, the structures that are involved are listed here. The one that I wanted to draw your attention to is the hippocampus. Why the hippocampus? Why the hypothalamus? Because that's where satiety and desire for food lives. Fine, fine, fine. This is not a neuroanatomy lecture. I thought this was about depression. Here's the challenge. Overeating, whether caused by depression or by your medication, is actually, we will look at it in a minute or 2, can actually quite directly cause oxidative damage and really cause challenges in the excitatory imbalance in these structures that control my mood. All of a sudden, what I put in my mouth, how much I put in my mouth, now interestingly affects structures that are not connected to my mouth, my brain, but they are. Remember the slide I showed you very early on? Obesity, depression, bidirectional negative relationship? That was not a coincidence. It's true at the neurobiological level. You don't believe me? Proof. Here's proof. Not an American study. This is a really cool landmark German study. They gave the same antidepressant to 3 groups of people. People with a BMI of less than 25, 25 to 30, over 30. They looked at blood levels too, because the thought would be, hey, the more weight you have, less blood level you have. Even after you normalize for that, just the presence of higher degree of fat, adipose tissue, makes it more difficult for antidepressants to work. This is, however, let's go back, perfectly logical now that we know more about the impact of adipose tissue, excess eating, on the human brain. Hold your thought just for a second. We'll cover it during Q&A. So no longer is adipose tissue not of great concern to psychiatry. It's actually a threat to psychiatry. Everything I'm trying to do for patients is threatened by increased amounts of adipose tissue. I'm changing gears on you one more time. Let's talk about the biopsychosocial aspects of the sexual response. And you will no longer, you'll have no challenge in accepting what I'm about to say. Sex is complex. Biology, psychology, sociocultural belief systems, and the relationship you have with your sexual partner, all of them matter tremendously. But I need to know more. You and I need to explore this in greater depth. Just focus on the left-hand side. This is the neuroanatomy of mood and depression. Right? No disagreement with me? I actually threw a spin at you. You should have disagreed with me. This is a neuroanatomy of sexual functioning. The reason why you agreed with me is because it exactly overlaps the neurocircuitry of mood. So when you heard this expression, I'm not in the mood, good God, completely right. Completely right. The overlap between sexual desire, sexual behavior, and mood, be it in either direction, optimism, happiness versus neutrality versus unhappiness, it is 100% overlapping. We're not done though. That's the neuroanatomy. Now look to the right. This is where psychiatry runs into trouble. So human sexuality absolutely involves a number of neurotransmitters. Dopamine is probably one of the most important ones. Oxytocin is the other one. The one we run into trouble is serotonin. And check this out. Serotonin, serotonin. In other words, at every level of the human mood, but also human sexual response, abnormal alteration of serotonin itself can worsen sexual dysfunction. Let's look at this in more granular detail. First, we will look at the central effects, then we'll look at peripheral. So when our patients say, I feel numb down there, they're not making it up. But first look at desire. Desire for sexuality. What happens to that? So if you look at desire, subjective excitement, orgasm, all of them really require the presence of a number of factors. Oxytocin, prolactin should be actually low, estrogen, testosterone, all of them are important. Please don't ignore how our neurotransmitters, dopamine, serotonin, norepinephrine, are involved in normal central sexuality, and how you and I can literally paralyze drive. You and I have heard patients say, I know sex is fun because I used to think that, but ever since we started this medication, sex seems like such a stupid idea. I can't believe human beings even want to have sex. Why? And then they come off the medication, they're depressed again, but the desire comes back. There's a strong sexual central effect, side effect profile to some of our medications, but watch this. There's also peripheral. And this, I think, as psychiatrists, we think everything is in your head. Well, sex is sometimes down there. And here we're going to talk about sensation. In fact, some of the SSRIs are used in men who have premature ejaculation. We used to think because it delayed ejaculation. Not necessarily. It actually decreases sensitivity. So it's a combination effect. Well, that's fine in a certain group of patients. This is tremendously problematic in other people, perhaps if they were already struggling with it to begin with. Vasocongestion is necessary in both sexes. in order to have A, satisfaction, and B, orgasm. That's impaired too. So let's go back. We have central side effects. We have peripheral side effects. So what do we know about the clinical data? Let's come back to the clinic. Enough talk. Let's talk about what do I do, what do I know. All of these classes are associated with sexual dysfunction, but there's differences. And the best way to know the difference is to know how much impact it has on the serotonin symptoms. And so, sorry, let me rephrase it. The best way to predict a medication's sexual dysfunction profile is to know to what degree it impacts serotonin reuptake, but there's another one. And to what degree does it offer me protection by increasing my neurotransmitters that are anti-sexual dysfunction? At the moment, the two neurotransmitters that have lowered the sexual dysfunction risk of SSRI, serotonin reuptake, is the presence of norepinephrine that cuts the risk by 30 to 40%. So SNRIs have a better profile than SSRIs. And the other one is, can a medication affect glutamate levels through 5-HT1A? And that doesn't sound like there's any proof to support that, right? No, there's quite a bit of proof, and there you are. So if you look at medications such as mirtazapine, nefazodone, low serotonin reuptake inhibition, then move to reboxetine, not an American drug, but it's a pure norepinephrine drug, just as a proof of concept. And as you move to duloxetine, desvenlafaxine, vilazodone, vortioxetine, look at these last four. Number 4 and number 3 bring in norepinephrine. Number 2 and number 1 bring in 5-HT1A. So no, this is not just theory. This is not theory. We still don't have a drug with no sexual dysfunction, but we now have drugs with decreasing levels of sexual dysfunction purely based on mechanism of action. There's nothing else that separates it. But you might again be wondering, is there real data? Or this is just very good conjecture? We have real data, absolute real data. So now we have 2 studies in acute major depression with vilazodone and vortioxetine. Both of them show superiority over SSRIs. They actually do in very well-controlled studies. There's another study in patients who are already free of depression, but they got sexual dysfunction from their SSRI. They were switched either to Lexapro, escitalopram, thought to be the lowest sexual dysfunction-causing antidepressant. Most of us probably say that, amongst SSRIs, or to vortioxetine, and vortioxetine beat it starting at week 4. No, mechanism of action actually does matter. It truly does matter. This is actually a pretty good paradigm. I won't go into it in any detail, but what it does say is, before you start your first antidepressant, explore patients' current level of sexual dysfunction. Because if you don't, how will you know whether you harmed the patient or helped the patient? How can you possibly do that? What you going to ask? How are things in the bedroom? Really, is that a question? I guess it's a question, but what's the patient to answer? How will you remember that 6 months down the road or 6 years down the road? Just remember this, please. Sexual dysfunction is actually very different with our medications. We don't have a 0 sexual dysfunction drug yet, despite what studies say. There are some studies that will say, so-and-so drug, the sexual dysfunction was no different than placebo. But look what they're saying. On average, patients' sexual dysfunction on placebo looked on average as a sexual dysfunction on a drug. It doesn't talk about outliers. So no, there are no drugs that I know of with no increased risk. It's just a matter of different risks. All right, let's keep digging. Everybody okay? Is this too much? Okay, the slow response tells me a little too much. But I thought you need the raw data. These are very important decisions you'll make for the patient. Patients hardly ever come in and say, give me that drug, and do it based on my cognitive profile and my sexual profile. We are where the buck stops, and we screw up, there's real consequences for the patient. Let's look at cognitive dysfunction. Here, there's very clear data. This, unlike weight gain, on cognition, the data is very clear. Mechanism of action absolutely 100% matters. Remember we talked about DSST? You guys remember that? using a real instrument, an objective real instrument. Different drugs have very different profiles on cognition. Well, let's walk our way through it. TCAs actually harm it. Harm it quite a bit. Look at the effect size. That's a pretty good level of harm. So don't put me on TCAs unless you clearly are okay with it, because there's a reason that I'm putting you on it. Monoamines, also a problem. SSRIs, not good, but not as bad as TCAs. Thank God. And then we have SNRIs. Do you see that red box? That's in the plus territory. But only one drug, and that's vortioxetine, actually did pop up and separated itself from others in terms of cognition. Those are not great effect sizes. 0.3 will not kind of rock your boat. But let me ask you this. You guys want to do something for me? Got to help me. Somebody here, please describe a headache. Describe a headache. You ever had a headache? Throbbing. Sharp. Achy. Say that again? Nauseating. Ugh, all of this sounds disgusting. Hey, you guys, describe not having a headache. But describe not having a headache. Impossible. It's actually kind of difficult. The reason why I'm asking you to engage in this exercise is this. It's easier to describe the presence of cognitive problems. It's close to impossible to describe the absence of cognitive problems. So patients will not be complaining to you about my cognition improved. So it's very difficult unless you're being very careful and ask them specific questions. So the way to understand you don't have a headache is to ask you, are you still nauseated? No. See, it's the presence of a negative that determines whether you improved or not. So don't be asking people, your cognition better? That won't work. But, oh, you were having trouble at school. How's that going? You were having trouble driving without often having fender benders. How's that going? That's a better way to do it. People cannot, I and you cannot describe the absence of cognitive problems. So you really have to know what cognitive problems you are having to track and see if it's improved or not. Silly example, but you guys with me? It's just a kind of a clinical pearl you and I could use. So at the moment, the database is this, and this is a true meta-analysis. We have level 1, level 2, level 3 evidence. That's bizarre, right? Erythropoietin? What are we, in a hematology conference? No, but erythropoietin has been studied. It has some database. Modafinil, level 3 mostly. SSRIs, SNRIs, depending on it, duloxetine is the only one that actually has level 1 evidence for learning and memory. What is so different about duloxetine compared to venlafaxine? Can anybody help me? That's right. Yeah, so this will support our point. Remember I said norepinephrine protects against the serotonergic side effects? So venlafaxine ratio between serotonin and norepinephrine just happens to be 30:1. It's not a bad thing. It's not a good thing. It's a thing. Duloxetine happens to be 10 serotonin to 1 norepinephrine. Not a good thing, not a bad thing. It's a thing. But do you notice the second drug is much more balanced towards norepinephrine? So guess what? Popped up here. So even amongst SNRIs, there's a difference among SNRIs. But the single best evidence for all 4 memory areas at the moment does appear to be vortioxetine. So key point to remember, antidepressants have different impact. Therefore, there will not be one good antidepressant. They're all good antidepressants. It's just a matter of what is his need, what is her need. All right, let's start wrapping up our conversation. Do you think physical exercise is good for you? Duh, but it's good for what? Oh, my monitor went out again. I'm burning out my monitor. What am I doing? But no, why do you think physical exercise is good for my weight? Well, why? Because it burns calories, right? Careful. Actually, not that much. So physical exercise burns about 10% of the caloric expenditure that you have per day. The real reason why exercise works is because it raises basal metabolic rate. And you and I burn 70+% of our daily calories, not through exercise. Oh, thank you. That helps. Okay, so I want to show you something interesting and cool about physical exercise that matters to you, me, in terms of cognition. So think about it this way. Physical exercise does appear to change glutamate GABA balance. So sexual dysfunction actually does improve in people who exercise chronically. You can't just say, I'm going to have sex today. I've had sexual dysfunction in 10 years. I'm going to go pump iron and things will be okay. It won't work that way. It won't work that way. But interestingly, chronic application of exercise, I want you to really focus on two things. Even though we don't exercise with our hippocampus, we don't. Hippocampus is a direct recipient of benefit, direct recipient, even in aged mice and older human beings. It is so immediate. Within 10 days of physical exercise application, even on a silly little MRI, you can watch the volume of the hippocampus go up by 16 to 20%. It is rather impressive. I just completed a pretty recent review of the role of exercise, cognition, and volumetric changes. I am stunned. That's the reason why I was in the gym yesterday while you guys were drinking in the bar. But look at that. Cognition is a direct beneficiary of physical exercise. It does work, but check this out. Oof, this one really took my breath away. Exercise is good for everybody. It is really good for people with depression. And I do know that depressed people have the hardest time exercising. I get it, but watch this. This is the curvature for healthy control. See, exercise absolutely is helpful, no question. But this is major depression. The dark line is major depression. I'm showing you the relationship between inflammation and mood and cognition, a triple relationship. We will have to find, guys, of somehow getting our depressed patients to exercise more. And the reason for that is so many different reasons, but in terms of weight gain, it helps. In terms of sexual dysfunction, it helps. In terms of cognition, it helps. So sure, we can talk about medications all day long, and we should, but non-pharmacological treatments are really important. As is sleep, Dr. Dogramji's talked before. Helping people sleep improves their cognition, improves their sexual dysfunction, improves their weight. So for all those reasons, let's remember pharmacology and non-pharmacology. I do have a case presentation, but because of time, I'm not going to do the case presentation. I hope you guys will look at the case. It's a relatively straightforward case, but I want to do this, ARS questions with you guys, and then we'll invite Chuck over so we can do our ARS questions. So I'm just going to make a few key points, if you'll permit me. And let's do it together. 3 issues that I said I will talk about: cognitive dysfunction, weight gain, and sexual dysfunction are 3 things. They're common, impairing, and disabling. I don't think you're going to disagree with me. I would love for you to remember that proactively looking for them is really in the patient's best interest, just makes us better clinicians. This meeting is called Elevate for a reason. If all you want to do, and I want to do, is same old, well, why are we here? We want to elevate it. We want to do things better. Well, one of the ways to do things better is to proactively keep in mind, educate patients, and measure. But you might say, it will take my time up. I only have 13 minutes per patient. Remember, you don't fill out any of these scales. You don't fill out any of these scales. All of these are patient-filled out scales. Do consider using it. And the final key point I would make, and I'll start from the bottom, non-medication treatments are very important. Just because I have the power of the pen does not mean all I should do is prescribe medications. Physical exercise. There are many things, but physical exercise and sleep hygiene are the top 2 if you want to help people with cognitive dysfunction, weight gain, and sexual dysfunction. But pharmacology, I'm not going to walk away from pharmacology. Look, democracy is a wonderful thing. I was born in the world's largest democracy, India. I live in the oldest democracy in the world now, America. I'm a big fan of democracies, but what am I going to do with a democracy when it comes to medications? Do I want my medications to be same or different? Different is good. So I have all these options. It's just my responsibility, so I know the differences so that I can exploit them. You give me that? Can we try that again? Do you give me that? Those differences are to be exploited. Okay, hallelujah, perfect. Hey guys, thank you very much for your cognition. I appreciate it.
All right. So we're gonna, just one question in the interest of time. We want to try to kind of make sure we stay right on it. This is a good one,
Okay.
I think. For patients who develop sexual side effects soon after initiating a new antidepressant, how long do you typically wait to see if those side effects decrease before you switch agents?
Yeah, that's actually a really, really
It's
good
a good
question.
Yeah.
But I would have to complicate it.
Okay.
The sexual dysfunction did appear. How well does the patient and their partner willing to tolerate it? Sometimes, if the depression has been catastrophic and severe and the relationship is strong, they will say, don't like it, but I'm willing to wait 3 months, 6 months. We'll get this depressed episode behind us, then we'll talk about switching. But in many of the circumstances, it is such a challenge that I'm much, much more likely to switch within 3 or 4
Early on.
weeks. Yeah.
Yeah.
If you have that clear a signal of sexual dysfunction within the first 2 or 3 weeks, the odds are it's A, going to be severe, and B, persistent.
So we used to say that it maybe sexual side effects get a little better with time. Has there been any research?
There has been. The problem is this: for every 1 patient who gets better,
A couple get worse.
there's a 1 to 2 patients who develop it. Sexual dysfunction is really challenging because sometimes it can be so subtle, particularly in women. It can be so subtle that they roll it into their lives. This is who I am, I'm aging, And then it's only when they stop taking it if there's a reemergence.
Yes, I've seen exactly this. It's a continent of trouble we don't talk about enough, isn't it? It's kind of a buried continent.
Yeah, this is not a issue that should stay in the bedroom between a couple. It should come into our clinic room as well.
So true. All right, thank you, sir.
Thank you.